Hello everyone. Today, in this series of topics that you missed to read from Harrison, I'm going to discuss about the most important infection of the gastrointestinal tract, that is the Clostridioids difficile infection, including pseudomembranous colitis. First of all, remember, unlike the other infections, Clostridium difficile infection is a unique one because it is most commonly associated with antimicrobial use. Okay, and it is mainly because of the disruption of the normal colonic microbiota, and that is why it is the most commonly diagnosed diarrheal illness which is occurred in the hospital. Then, coming into the etiology and epidemiology, Clostridium difficile is an obligate anaerobe. It is a gram-positive spore-forming bacillus, most commonly seen in the environment of hospitals and chronic care facilities. And it occurs frequently in hospitals and nursing homes. And what are the group of antibiotics? This is a very commonly asked question. It is clindamycin, ampicillin, and cephalosporins. These are the first antibiotics which are known to associated with Clostridium difficile infection. That means these are the antibiotics which has increased risk of CDI. And the second and third generation cephalosporins are also frequently responsible for this condition. And even we have now found that even the so-called as the higher antibiotics like vancomycin are also found to have subsequent risk of Clostridium difficile infection. And remember, the rate of fecal colonization, it increases in proportion to the length of the hospital stay. That means the more time you stay in the hospitals, okay, the more will be the fecal colonization of this bacteria. And remember, what are the identifiable other risk factors for CDI? It is old age, greater severity of underlying illness, GI surgery, electronic rectal thermometers, enteral tube feeding, and antacid treatment. Coming into the pathology and pathogenesis, it has two toxins. One is toxin A, which is an enterotoxin, and toxin B, which is a cytotoxin. And remember, toxin A is a neutrophil chemoattractant, and toxin B is the most important virulence factors. And once this toxin enters the body, there will be disruption of the cytoskeleton, which results in the loss of cell shape, adherence, and tight junction with consequent fluid leakage. And remember, the pseudomembranes, okay, which are formed as a result of Clostridium difficile infection in the colonic mucosa, that is what we call it as pseudomembranous colitis. They are confined only to the colonic mucosa, okay, and it appears as a 1 to 2 millimeter whitish yellow plaques. Okay, yes. And as this disease progresses, as you can see in this picture, it forms larger plaques and becomes confluent over the entire colonic wall. And on microscopy, we can see that these pseudomembranes have leukocyte, fibrin, mucus, and cellular debris. Okay. Once that is done, see, as I told you, the healthcare exposure, increased chance of receiving an antibiotic, okay, and increased chance of being exposed to spores of Clostridium difficile. So coming into the clinical manifestation, diarrhea, it is the most common manifestation of Clostridium difficile. Clostridium difficile infection, characteristical present as a diarrhea, okay, but unlike the other cases of diarrhea, which resolves over a period of time, CDI diarrhea won't resolve over a period of time. That is how we have to immediately think about, okay, whether he's on any other antibiotics, because of which, or whether there is any disruption of the normal colonic microbiota that is responsible for the CDI. And remember, the diarrhea is watery or mucoid in consistency with a characteristic odor, and most of the patients will be associated with leukocytosis, and in some cases fever and abdominal pain are also present. Coming into the diagnosis, this is actually the diagnostic criteria to establish a diagnosis for CDI. Number one, diarrhea more than or equal to 3 unformed stools per 24 hours for more than or equal to 2 days. That is actually the definition for diarrhea. Okay, with no other recognized cause. That is number one. Number two, we have to detect the toxin A or toxin B in the stools, or the by using the toxin producing Clostridium difficile assays like the NAT, that is nucleic acid amplification test. Okay, or PCR, or by culture, or we have to visualize the pseudomembranes in colon. So remember number one, diarrhea with no other cause. Number two, detection of the toxins either in the stool or by nucleic acid amplification test, or by PCR, or by culture, or we have to visualize the pseudomembranes in colon by colonoscopy. And remember, the confirmation of the presence of toxin in the stool, in addition to the NAT, or we have another assay, that is the glutamate dehydrogenase positivity. It is actually recommended in the European CDI guidelines for diagnosis of Clostridium difficile infection. So this is actually a picture that shows, okay, this is a very commonly asked question, which is more sensitive, which is more specific. First of all, I will tell you the most sensitive test is actually the the stool culture for Clostridium difficile, which is actually the most sensitive test, and the highly specific one. Okay, highly specific one. Okay, here it is shown 4 plus. 4 plus means more than 90%. Okay, so more than 90% specificity is cell culture cytotoxin test on the stools. So most sensitive, I can first go for stool culture for Clostridium difficile, and highly specific, I can go for cell culture cytotoxin test on stool, which is highly specific. The second highly specific one is the colonoscopy or sigmoidoscopy. Okay, so combined cell culture cytotoxin test on stool along with the colonoscopy and sigmoidoscopy, that has the highest specificity. Of course, in sensitivity, there is no doubt, it is always stool culture for Clostridium difficile. So coming into the treatment of Clostridium difficile infection, earlier, okay, we use many agents, okay, many agents for the management of CDI, but now, okay, that is earlier we use metronidazole, okay, earlier we have been using many other drugs for the treatment of CDI, but currently as of 2021 guidelines, it is oral fidaxomicin which is considered as the drug of choice, okay, and oral metronidazole is used only in case of mild or moderate CDI or when the fidaxomicin or vancomycin is not available. Okay, I will come to this table. See, whenever there is a mild to moderate episode, initial episode mild to moderate, drug of choice, always remember it is oral fidaxomicin. And remember, this is a very common mistake that everyone will tell, we use IV vancomycin. No, remember IV vancomycin is associated with increased subsequent risk of CDI. Okay, so never we use IV vancomycin. So the route of vancomycin that we use in the treatment of CDI is always oral vancomycin. So fidaxomicin is a drug of choice. If not available, we can go for oral vancomycin. So suppose if it is initial severe episode, we have to always go for oral vancomycin, has to be preferred than oral fidaxomicin. Okay, yes, and indicators of severe disease is leukocytosis and raised creatinine. And initial episode, it is fulminant. In this case, remember, there is no role of fidaxomicin. We either go for oral vancomycin or oral vancomycin along with metronidazole. So remember, drug of choice for mild to moderate initial episode is fidaxomicin. Okay, just remember fidaxomicin. Suppose if it is severe initial episode, it is oral vancomycin first. If it is fulminant, it is always oral vancomycin combined with metronidazole, IV metronidazole. Remember, there is no role of IV vancomycin. What is fulminant CDI? Severe CDI, that is leukocytosis, raised creatinine with hypotension, shock, ileus or toxic megacoli. Suppose in case of there is recurrences, okay, in the case of recurrences, currently the treatment protocol is combined fidaxomicin with oral vancomycins. And there are patients at high risk of recurrent CDI. We have recently developed a new monoclonal antibody that is called as besilotoximab, okay, which has to be given IV. So remember, mild to moderate, it is fidaxomicin or vancomycin. Severe initial episode, oral vancomycin. Fulminant, it is oral vancomycin with IV metronidazole. There is no role of oral fidaxomicin there. In case of recurrence, vanco along with fidaxo. Okay, yes, in multiple recurrence, yeah, the recent treatment modality which has been emerged is fecal microbiota replacement therapy, so called as FMRT. Fulminant, severe CDI with addition of hypotension, shock, ileus or toxic megacolon. And as I told you, sepsis, hypotension, all those happens. So in case of severe complicated or fulminant CDI, the patient usually presents the case an acute abdomen with signs of obstruction, ileus, colonic wall thickening, ascites, okay, leukocytosis more than or equal to 20,000. And as I told you, in case of fulminant CDI, we go for oral vancomycin with the IV metronidazole. Okay, yes. And the role of oral fidaxomicin in treatment of fulminant CDI is not well established. So coming into the prognosis, it has good prognosis. And remember, prevention and control is very, very important because hand hygiene is critical. Gloving of personnel, elimination of use of contaminated electronic thermometers, use of hypochlorite bleach, everything is important. And we also have to restrict the use of specific antibiotics such as clindamycin, second and third generation cephalosporins and fluoroquinolones, which has very high risk of CDI. So with this, I completed the topic Clostridium difficile infection. Remember, it is hospital acute. Obligation rope, spore forming, clindamycin, first and second generation cephalosporins, increased risk. Remember, IV vancomycin never used in the treatment of CDI. Only it is oral vancomycin. Okay, toxin A, toxin B. Most sensitive, stool culture for Clostridium difficile. Highly specific, combined colonoscopy with cell culture cytotoxin test on stool.